Hello everyone, this is Dr. Rajesh Mishra and you are watching your own health super specialist. So it has been a long time after COVID and again it seems the small spikes are coming. So in my previous videos you have learned a lot about COVID pneumonia. Now let's discuss something else, something more conventional. So this topic is community acquired pneumonia. What is community acquired? As the name suggests, any pneumonia which is acquired from the community. To be more specific, as you know, you are watching Health Super Specialist, and I am bound to give you information very specific. So, if you want to define a community acquired pneumonia, the practical definition stands like any pneumonia in which the cultures, be it sputum culture, be it ET culture, is positive in the initial 48 hours of admission to any hospital is termed as community acquired pneumonia. Remember, 48 hours. That means the infection has been acquired from the community and it has manifested or it has landed up in the hospital. That's community acquired pneumonia. In literal terms, it is inflammation and consolidation of the underlying lung tissue. That is the basic definition of community acquired pneumonia. Now, what are the ways in which a pneumonia can be acquired? Most commonly, it's like aspiration. And as we all know, but all of us, when we sleep, when we lie down, we have small component of micro aspiration, which is to the extent of like 1 to 5 ml. Supposedly, if someone is elderly, more than 65 years old, that aspiration component increases. A smoker, an alcoholic, the aspirational component increases. So, aspiration is one cause of community acquired pneumonia. The other cause are like, a part of aspiration, it can be inhalational. Legionella infection, it is inhalational infection. All sorts of viruses, COVID, respiratory syncytial virus, human metapneumovirus, all these are inhalational. So, aspiration, inhalation, and hematogenous infection can also be there. Bloodstream infection, that can also cause community acquired pneumonia. Now, what are the risk factors? Like, who all are more prone to develop this community acquired pneumonia? Any person who is more than 65 years. That doesn't mean that a 30-year-old male will not develop in community acquired pneumonia. Yes, they will definitely develop, but then it will be mild and the organism may be due to inhalation. So, more than 65 years people are more at risk. Diabetic, hypertensive, history of COPD, history of interstitial lung disease, history of connective tissue disease, history of CKD, on steroids, immunosuppressed people, and the list goes on. So these are the common people who are predisposed to a greater incidence of community acquired pneumonia. Fine. So how do I know what are the features of community acquired pneumonia? The typical features will be cough, fever, sputum production. The cough may or may not be associated with sputum production, but definitely it is one of the clinical symptoms. Pleuritic type of chest pain may be there. In the elderly, there may be non-pulmonary manifestations of community acquired pneumonia, like as altered sensorium, confusion, uremia, like blood urea nitrogen goes above 20 milligrams per dl. Tachypnea, respiratory rate is more than 25, more than 30. So these are the symptoms of a community acquired pneumonia. Dyspnea on exertion, shortness of breath, generalized malaise, fever, and other non-specific findings. So anyone who is having these features, is it like community acquired pneumonia? No. There are a lot of differentials. A lot of differential diagnoses are there for community acquired pneumonia. What are the differentials? A patient may have acute exacerbation of COPD. Simple. With a background of COPD, patient may have acute exacerbation due to which the patient may have the symptoms. The patient may have other connective tissue diseases. The patient may have a simple MI, which is a great differential of community-acquired pneumonia. The patient may have other ailments like acute bronchitis. The patient may have pulmonary embolism. The patient may have congestive cardiac failure. The patient may have hypersensitivity pneumonitis. So lot of features may be there which mimic like a community acquired pneumonia. So we have to keep in mind the mimics of community acquired pneumonia and proceed whatsoever. So these are the common mimics of community acquired pneumonia. Now getting more specific, what are the typical signs by which we diagnose a community acquired pneumonia and then decide whether to treat at home, whether to treat it ward, whether to treat it ICU. I'm an ICU guy, everybody knows. So if there are lots of criteria, we will have a separate videos on the criteria itself, but going very concisely, you can have issues like as curb 65. Curb 65 is confusion, urea, respiratory rate, and the blood urea nitrogen, and age more than 65. Any score of curb 65, each point will get a specific score, and any score of more than 4 requires ICU treatment, 3 to 4. Curb 65. Then there is pneumonia severity index. The port score is there, and then the ATS score is there. The ATS score is very simple, 2 major and lots of 8-9 minor criteria are there. The 2 major criteria as like shock and requirement of mechanical ventilation. Minor criteria, the respiratory rate, hypotension, thrombocytopenia, hypothermia, tachycardia, multilobar infiltrates in the chest X-ray. So if 1 major and 2 minor or 3 minor are present, you decide the patient has to be taken in ICU. And depending on the class, you have to decide whether the patient needs to be admitted in hospital or have to be treated on an OPD basis. So this is very important when you see the patient, whether the patient has to be admitted to a hospital or the patient has to be admitted to ICU or he has to be treated at home. So the diagnosis and the management part will continue in our next video, not to lengthening this video. Till then, keep watching. Thank you very much.